All right, we're live. Hi, guys. So for those of you guys who are watching us, we are group 24, and tonight we'll be talking about case 4. Before we begin, my name is Keith, and I'm the first year medical student from VCOM, and then we're going to go around and introduce ourselves. Take it away, guys.
So, hi, I'm Emma. I'm also a first year from BCom.
Oh, I'll go next. I'm Fatima. I am a senior nursing student from USC Upstate Mary Black School of Nursing.
Can y'all hear me?
Yeah.
Okay, I'm Josh. I'm from PC. I'm a year 2 student.
And my name's Matt. I'm from Presbyterian College School of Pharmacy and P2 as well.
Mark? 1 second. Mark is having... Let me call Mark real quick.
I was going to ask you if you wanted to introduce him. Because we can see
him. Yay, technology.
Yay.
All right. Mark is having some mic issues, so he's right here.
Okay.
Mark, can you introduce yourself?
Oh, hey guys. Can you guys not hear?
Oh, we can hear you now.
Yeah, maybe this will help. Go ahead, Mark.
Can you guys hear me?
Yep.
Yeah.
Can they not hear me?
Everyone can hear you.
We can hear you.
Oh, I can't hear anyone else. Oh, because you got the dang thing on. Okay. Hold on.
Oh, you can't hear us. Okay.
Anyone else that? I don't think this.
All right, Mark, let me try this. You guys can still hear me, right?
Yeah.
Yep.
Okay, Mark, I'm gonna use my mic, and you can hear everyone now. You should be able to hear everyone now.
He's gone.
This is a clusterfuck.
So, Mark, everyone can hear you, and you should be able to hear everyone now.
Kind of. Not really. No.
Can someone say something?
Yeah. Can you hear us? You can go ahead with your intro.
Take that as a no.
I can, but not very clearly. I mean, okay. Well, the only thing is they will have to hear me on the recording. We started recording?
We are recording. We're recording.
Yeah, and we can hear him.
Everyone can hear you, Mark. Everyone can hear you.
Yeah.
Oh, well, Dr. X is just going to have to fast forward through 10 minutes of...
Now we're still good. But you can hear Fatima and Emma, right, just now?
Yes.
Hello.
Yeah. It should work.
Okay.
Okay.
All right. So, Fatima, do you want to go ahead and read the case?
Sure. Okay, so case 4. We have MB. He is a 36-year-old African-American male. He has been diagnosed with schizoaffective disorder since 2010, and he has periods of paranoia and delusions. He's currently a resident at the state psychiatric hospital. So in the past, he's had several episodes of delusions that caused him to become combative to the nurses because he believes that the IV lines are transmitting information to the NSA. He consistently rips them out. Now, in one incident, he pulled one out so hard that it knocked down the IV pole, which hit a nurse and resulted in the nurse getting a black eye. The nurses have asked the doctor for restraints for their own safety. The social worker reports that upon admission, the family asked that no shackles or white coats be used on Mike. In an effort to follow the family's wishes and the requests of the nurses, the doctor consults pharmacy for chemical restraints, such as benzodiazepines or haloperidol, to control the patient's combativeness. The pharmacist remarks that the patient has refused benzos in the past because he feels foggy-headed and not himself.
Thank you, Fatima. So our first question is, what is the problem facing the team or individuals?
I can talk from a nurse's perspective. From the nurse's perspective, their problem is safety. They want their patient to be safe. They don't want him to inflict any more pain because they have to continuously keep sticking him every time he pulls it out. Right. And they want themselves to be safe from his violent behavior. So I'll just talk from the nurse's perspective.
Mm-hmm.
That's their issue.
Mm-hmm.
And from the physician's perspective, the problem would be trying to mend all of the sides of the problem, from the family to the patient's clear distress, as well as the nursing staff.
Right. Hold on a second. Mark has something to say. Mark?
I was also thinking from the standpoint, we're obviously taught as physicians to respect the patient's wishes and their autonomy. So that's kind of the other side.
Okay.
And I think from pharmacy standpoint, the issue would be the patient's refusing medication as it is. So from the pharmacy standpoint of things, if they're refusing medication, our hands are kind of tied in that respect, in that we're not supposed to be administering medications to patients if they're refusing because of what the medication can do and how it can affect the patient as a whole.
Yeah, makes sense.
The main problem is the safety of the nurses.
Mm-hmm.
Yeah. So I thought about it too. To be honest, I really think that the problem is more about the safety of my staff, right? The medical team, the doctors, because you never know what this patient is going to do next. He might hide a fork and then try to stab someone. We don't know. And the fact that the patient has been having paranoia and delusions, that is quite concerning.
So obviously something needs to be done.
Mm-hmm.
We can't just say that the patient doesn't want anything done, and we can't just leave it there.
Mm-hmm. And go ahead. Go ahead.
I was just gonna say, as far as upholding the autonomy, this is me personally. I felt like what the patient wanted moreover, and I understand he has altered mental status, but I'm thinking what he wants moreover than what the family wants. They're saying they don't want these restraints based on. They're not saying they don't want it based on the fact that he doesn't want it. They don't want to see him in that condition. This is what I'm getting. So right. I feel like the restraints would be, me personally, again, it's less invasive than giving him medication that he may have to deal with the side effects and things from. And also it's their request. So we'd have to sit down, as a group and meet with them and say, hey, this is what we need to do. He does not like the way these medications make him feel. Haloperidol is really strong. It has EPS issues and things like that. So that's how I'm looking at it from.
Mm-hmm. Makes sense.
I also think
my one question is, if we decide to restrain him, what's going to cause him to be more agitated? The drugs or doing something like soft wrist restraints? Because the last thing I would want would be, to restrain him. Obviously we need to think about safety, but if it's going to cause him to get all agitated, that in itself is going to cause problems.
Yeah, in that aspect, we can have the pharmacy team to kind of chime in. I do know that chemical restraint is more invasive compared to regular physical restraint, because regular physical restraint, you can just put 2 mittens and tie the mittens to the bed frame. That's pretty much it. Well, Matt and Josh, what do you guys think?
Well, based on my experience in Bryan Psychiatric Hospital here, not here, but in Columbia, from what I've seen, respect goes a long way with patients, and And when it comes to their requests as far as restraints and shackles and being tied down and all this other stuff, there's a certain amount of autonomy that they do have, but then it also depends on this specific patient how far into his psychosis is he, to where his autonomy personally is limited to where the autonomy would shift to his family.
Right.
So you're right when you say that if we restrain him, then it may make him more combative, and his family probably knows this.
Yeah, for those of you guys who are watching, we're already on the second question. So the second question goes, as a team, decide how you would address this situation. Now we're torn between whether or not we should restrain or not to restrain, right? Because if we restrain the patient, we protect ourselves, the safety of our staff. And also we're protecting the patient, right? But this is not something the patient wants. That is the problem. Personally, I would go with restraining the patient, because my reasoning is I'm protecting my staff and I'm protecting the patient from harming himself more and more, right?
Yeah,
Even though it means, oh, go ahead.
Keith, when you say restraints, are you referencing the chemical restraints or the physical? Or are you saying either or?
No, it's physical restraint. Let me clarify that. Physical mittens, just mitten. Yeah, so that he doesn't pull anything out of his way, or the IV lines and all that.
I guess this is a question for those farm guys. Just kind of thinking out of the box. Is there anything other than benzos or Haldol that we could use? I mean,
it's all
maybe just a I don't want to say sedative, but just something light that maybe doesn't give him the same side effects, but calms him down enough to where he's not having this paranoia, this like agitation.
Hey Josh, if you're trying to speak, I can't really hear you. You might want to hold your mic up to your face,
Okay.
Closer to your mouth.
I said you could use like mood stabilizers, but I think those take like a few days to take effect, so that might not be something you could use
It
right away.
just depends on something that the patient's going to be responsive to, because you could pick a drug that's got a long half-life and you would still have to stick them to a chair for 3 days before the medication even decides to kick in. So like,
what about something like a tricyclic antidepressant or any of those other?
Well,
I don't know. I'm just shooting for anything that'll not have those same effects, but still gets the job done.
Those take like weeks to start working.
Yeah.
So I mean, that is something that we'd have to address, and that may be where the physical restraints would, I don't know, maybe play a small role in getting him across that gap. But
I think another thing that we should consider here is, and we don't really have enough information from this little like innuendo, but like, what is he receiving in the IV, and is there alternate ways to administer the medication that he's getting IV, possibly, and just trying to reduce the amount of time he's hooked up to an IV altogether, if that's what's really bothering him.
that would be a really nice solution if we could just give them everything by mouth. And then
in my experience, because I do work in the ER as a tech, especially in cases with schizoaffective disorder, they're gonna spit. We had a gentleman hiding things in his beard, so they're not gonna take it. But we have spoken to family. We always prep them if the person has been restrained. We'll sit them down and, we'll have everyone in the room and we'll prep them and say, this is not a permanent fix. This is just something, and we'll explain exactly what they've been doing, because nobody wants to know that every day their family member's getting stabbed in their vein again and again. So we'll just, explain it, say, hey, this is exactly what's happening. He's harming himself. This is the nurse with the black eye or whomever. And this is temporary until we can talk to pharmacy and maybe come up with something, that maybe he would be willing to take, or let him know it's not a benzo, or, maybe a little more communication.
Sounds good. So as a team, we agree with the physical restraint first, right? As a short term.
Yeah, for short term, just to make sure everyone else is safe. Because obviously, if we start getting hurt, then we can't. That does a disservice to the patient. We can't really do anything after that. But I think that's maybe a good stepping stone to eventually getting to that.
Mm-hmm. And then long-term goal would be to look at the potential drugs that we can use to stabilize the patient, right?
Mm-hmm.
Yeah. Okay. Any additional thoughts before we move on to question number 3? Nope. Okay.
No.
Moving on.
Okay.
So, number 3, what ethical principles did you use to guide or justify your solution?
I actually wrote mine down.
Okay.
Well, I read it through, and this is just coming again from my perspective of starting with the restraints. But later on, I can say, those doctors did that. No, I'm kidding. But I started with the autonomy.
Bullets, so.
I know that's terrible. I did start with autonomy. I said, well, if he's stating that this is not what he wants, and I know the family doesn't like the restraints because it's hurtful to see that. We'll start with what he wants. So let's stay away from the medication. We'll use the restraints. And then my next guiding point was the non-maleficence, which of course is the do no harm. And that has to do, it's not, and of course we do come first. The staff, like Keita always says, you have to take care of your staff. But as nurses, we always think patient first. And a patient harming us is very similar to them harming themselves. Because if they're swinging, they can hurt their arm, they can hurt their leg. Anything that they do, they may regret it later when they wake up and say, "Oh my God, I did all these things while I was out." So that, for me, those were the 2 top ones: was the non-maleficence and the autonomy.
I think another big one here is just justice and trying to do what's fair for everyone and thinking about us as a collective, including the patient, the family, and the whole medical team. And we kind of weighed the options of what's best for everyone and then do no harm and what's best for the patient at the end of the day.
Yeah.
Mark, you have something to say?
I think you guys hit the nail on hit the hammer on the nail. But I was going to say autonomy right off the bat. We try to think about the person as a whole and what their wishes are. And unfortunately, I feel like there's no real situation that's going to suit everyone. So we need to find a good ground. And that's where justice comes in. It's trying to figure out where, what do you do that's best for everyone?
All right. Sounds good. Matt and Josh, do you guys have any additional comments?
I definitely think non-maleficence is in there because you definitely want to avoid harm to the staff or you can't help the patient.
Right. Gotcha.
Do
we want to go ahead and just lay out what our final answer is, like what a collective plan for this patient would be?
Definitely non-maleficent. That's a big one, right? Doing no harm. So by saying that, we're saying we're going with physical restraint because the reason why we restrain is to do no harm, not just only to the patient and families, but also to the medical staff.
Yeah.
Right.
Do we think that's best for the nursing staff and everyone to comply with?
Yeah.
We have to think about how hard it would be to implement this plan.
It shouldn't be too hard. As long as we can explain to the patient, not to the patient, sorry, to the family members. The family members are very important here. They're gonna go against us, but then I think, or I truly believe that if we have valid reasons of our actions, they should be able to comply.
And I think we do. I mean, safety is a pretty big concern here, so I think that in itself kind of warrants at least some action to be done, like we said before.
Right. I mean, I can have the patient beating up everyone. Everyone is going to take sick leaves and all that.
No one's going to want to come to our hospital. Everyone gets
black eyes.
All right. So if there are no additional thoughts or comments, that pretty much concludes our video conference for tonight. So for those of you guys who are watching, again, we are group 24, and our case is case number 4. And that's pretty much it. Thank you, guys.
Thank you.
Thank you.
Yeah.
Have a good night, guys.
Bye. Thank you.
Bye.